At the end, maybe you didn't hear me, so I'm very happy. It's a privilege to be here. Thanks for the invitation, and being a returning speaker is particularly challenging and a particularly honor. And I started telling you that the Latin used to say dulcis in fundo, that means the sweet at the end, even if most likely, being lunchtime, you would prefer me to talk about lasagna bolognese or something like that. But I'll be proudly trying to convince you that also PET-CT has a role in the imaging of prostate after those really nice and educative talks about especially MR. Well, the story begins with FDG. Everybody knows that FDG is the most widely used tracer, but unfortunately is almost always negative in prostate cancer imaging. That's been known since a long time ago. That's an example of a patient. The prostate is there. It's been treated with external radiation therapy. There's clearly a lab recurrency, and there's no FDG uptake. So essentially, the key point for the people working in PET is that we cannot use FDG because it's too poorly sensitive. Well, we are talking about metabolic imaging, so we have several tracers that may depict different receptor or different metabolic pathway, and the suggestion was about the use of choline. Choline is incorporated into phosphatidylcholine, so it traces the cell membrane turnover, could either be labeled with carbon-11 or fluoride-18, and indeed, it's everything but new, because the Japanese colleague introduced the use of choline more than 15 years ago. So it has been originally suggested for imaging prostate cancer in the last century. And that's the same patient that I showed you before that was completely negative at FDG imaging. And the local recurrency, it's clearly demonstrated by carbon-11 choline. That's another example from our files in which a patient with no pathological uptake of FDG has several areas of pathological uptake of choline. Well, now, of course, we don't perform any more dual study in the same patient. It was just the prospective study at the beginning of our experience, just to show you the fact that it's very common that you have FDG negative and choline positive scans. That's another example. Again, here you can see a large presacral lymph node here, which is again completely negative at FDG and clearly positive at choline. So there's no doubt that the method is much, much better. And there's been a lot of literature coming out in the last decade, and essentially it comes from Western Europe. So mainly it was Germany, Italy, and Netherlands, and also Switzerland and Japan. That was related to the fact that carbon-11 choline has no commercial interest. So in the US, they have to pay the price of lack of support from the companies. And only a couple of years ago, Mayo was the first start using carbon-11 choline. But I guess we can be very proud to be at least 5 or 7 years ahead of the Americans in this setting. I'm sorry for the Americans down there, but this is the reality. So let's come to the clinical scenario. The surgeon and the oncologist emphasize the fact that there are very different scenarios in which you may like to use PET-CT. That could be primary diagnosis, staging, recurrency, and therapy planning. And I'd like to briefly cover all of them. That's an example of the use of choline for identifying a tumor that escaped a previous assessment. It was a negative mapping. You know, it may occur in about 10% of cases that very strong suspicion is negative. And in this case, as you can see, it could be identified. So there have been some hopes with that. But unfortunately, as we published about 10 years ago, it's not only the cancer to be avid of choline. There is many false positive findings because also the PIN, which is a precancerous situation, it's positive, but also prostatitis. So there's a very poor specificity of choline in this setting. That's another example. As you can see, it's not only the tumor which will take the choline, but also some A-grade PIN situation. And that's been confirmed by other papers. So essentially, in the setting of primary diagnosis, there's no doubt that choline has a very, very little role to play. It's definitely the domain of MR, so there's no discussion about that. Another setting could be staging. That's an example in a patient in which, apart from the primary tumor here, we do depict the two lymph nodes. And of course, it could make the difference for the surgeon to know where it has to be extended, the lymphadenectomy. So in this case, and we performed a prospective trial in which the results of lymphadenectomy, pathological results, were compared with the PET findings. Well, unfortunately, like in this case, the primary and one lymph node was observed. It's here. But the other lymph node was missed. And that was the unfortunate point that was confirmed, and mostly related with the size of the lymph node. It's very frequent that the size of the lymph node involved by the disease are not that big, and unfortunately we know that the resolution capability of PET is limited to something like 5 to 6 millimeters. So we definitely will miss all the many lymph nodes of small dimension. So again, there's a very minor role for PET in this setting, apart of a few selected cases in which is questionable an enlarged lymph node already documented by CT or MR. And there's been this comparison recently in which it was surprisingly in favor of choline as compared to diffusion-weighted PET, MR, but it's only related to lymph node staging, so it has nothing to do with local prostate invasion and extension of the disease. So there's no doubt that for lymph node staging, we can give some information in selected patients, but definitely not for the local disease. And there is already a meta-analysis on that in which it is confirmed that the key problem is the low sensitivity, because we will miss a lot of lymph nodes. So there is a role, but it's quite limited. But let's come to the good news, so to the spoonful of sugar that I'm going to try to give you. The suspect of relapse, which is a major clinical problem. It has been emphasized by the surgeon and the radiation oncologist. After intervention, about 30 to 40% of patients will experience a lab recurrency. That's to say the PSA will rise up, and the patient will get crazy about that because there's no clue about where it occurred. And that's probably the setting in which PET-CT can really make the difference. That's an example of a patient already treated. The PSA values is high, of course it's pathologic, but relatively low, so not that high. Doubling time, which is extremely important to us, is short, so there's very rapid increase of PSA, and bone scintigraphy was negative. And PET identified this only lymph node here. That probably was also pathologic by the CT point of view. Let's get to another example of a single lymph node as documented by PET-CT. Of course, there are all images with the carbon-11 choline. And that's a more interesting case in which a bone, very early bone lesion could be documented, as you can see here. And in this case, bone scintigraphy was negative, PSA was pathologic but relatively low, and CT was completely negative. So in this case, of course, the information was unique, and it made a complete change in the patient management. So it was determinant for the patient management. Again, the literature is becoming more and more consistent in this field, and again, it's coming mostly from Europe, so we can be proud of building up the data for the evidence base of the fact that you can use choline in this setting. And the good news is that it's not only about carbon-11, because everybody knows that carbon-11 imply on-site cyclotron, which is not commonly diffused, while fluorocholine can be distributed, and it's indeed commercially available in Western Europe. So you can purchase that, even in Switzerland it's available. And the data are very consistent for a diagnostic usefulness, which is very similar for F-choline and carbon-11 choline. There is a meta-analysis, very recent, which do demonstrate very high sensitivity and specificity for the detection, especially of local, regional, and distant metastases. So I guess that as a clinical use, at least in our institution and our experience, if you suspect a recurrency, definitely MR is the gold standard for the local recurrency, so the prostatic bed evaluation. But if you do suspect that the recurrency may occur at lymph nodal or bone level, choline is the way to go. And of course, if you want to treat the patient with external radiation beam, you may use the information provided by PET to extend the treatment plan or include lymph nodes that otherwise would have been missed. That's an example. Differently, I guess that in my institution it's very common that all the patients scheduled for external radiation after intervention, the so-called salvage radiation therapy, should undergo a choline in order to be sure that there is no lymph node involvement, like in this case, in which only in the prostate is pathologically taken, so the boost can be guided directly into the area of positive uptake. So, as a summary, I guess that we can consider choline PET-CT as a glass which could be seen as half empty or half full, if you're optimist or pessimist. So that the technique is there. Definitely is not optimal because the accuracy is suboptimal, especially in the prostate bed evaluation. But nonetheless, is most likely the more accurate method for lymph nodal evaluation and also for early bone detection. One of the major limits is the very well-known relationship between the PSA values and the sensitivity of PET with choline that has been reported since a long time, and there is also meta-analysis on that. It's been originally reported by German groups. So as you can see, the higher the PSA value, the higher the sensitivity of PET with choline. Well, unfortunately, in the clinical setting, we would like to be here. We would like to be very sensitive in the very early recurrency, because when the PSA is higher than 10, then there is no clinical impact. So you don't need to demonstrate that there is a bone involvement, because the clinicians essentially is already aware of that. And we would like to get higher accuracy at that level. And we do demonstrate that we do have to incorporate not only the trigger value of PSA for this purpose, but mostly the kinetic of PSA. So patient has to be selected if they have a short doubling time. So the PSA is rising rapidly. It's related to a better accuracy of PET with choline. And that's an example, again, of PSA with a short doubling time, negative bone scintigraphy, a very small lymph node here, which is correctly identified by PET with choline. And again, the quality of the image is quite good, and I guess that in Europe there are a number of centers working on that. And in particular, we focused on that, on the clinical relevant situations, that's to say patient with early increase of PSA. And again, I guess that in this setting, the use of PET with choline is for us almost routine. We are quite happy, our clinicians are quite happy, but nonetheless, of course, we can make it better. And that's the reason why we try to study new tracer to introduce in the area. And I will briefly try to describe to you what's going to happen very, very soon, because most of the new tracer are already into clinical trials in an advanced part. I would not talk about fluoride. I'm sorry, fluoride is not a new tracer. It's been available since 30 years. And the key point is definitely fluoride is better than bone scintigraphy, but will provide information on the bone status only. So it's not a tracer of cancer, it's just a tracer of bone turnover. So you may try eventually to replace bone scintigraphy. You will get better sensitivity, but you will get the same sort of information. So it doesn't make the difference to me to consider that as a new tracer. These are the groups in which you may consider new tracer to be available. That's hormonal receptor, essentially. Other different receptors that have been demonstrated to be overexpressed in the prostate cancer, of course, the PSMA tracers, and finally some amino acid. Hormonal receptors have been described long ago, especially in the US. There has been a lot of studies on that. Of course, it would be very tempting and useful to have information about the status of the receptor in order to guide the treatment. That's also the limitation to some extent. And the people at Sloan Kettering were pioneering those studies, and almost 10 years ago they reported imaging, successful imaging, with a fluorinated compound targeted to the androgen receptor. Nonetheless, it never gets to a relevant clinical role. And I guess the main problem is the fact that in any case, you will treat the patient with hormonal therapy, and you will get the information clinically. So most likely, those same information can simply be obtained by clinical evaluation of the patient under hormonal therapy. And indeed, there has been sort of reduction of the interest of this tracer that, in my view, cannot be considered as pretty new right now. Other receptor, I'm mainly talking about the bombazine receptor, because it's been demonstrated that prostate cancer has overexpressing the gastronodism peptide, just like many other solid tumors. So there have been attempts at developing gallium-labeled bombazine receptor. Unfortunately, the many hopes that especially the nuclear medicine people had were a bit frustrated by the publication last year of a very early phase human study, first human studies of a product that has been patented by a big company, Bayer, and was essentially a failure because it was inferior to choline. So essentially, I guess they give up the further development, which is extremely expensive and holds minor promise for the future. Well, probably the most rapidly growing and the most hopes are held by the PSMA tracer, which have been known since long ago to have a very good target, but at the very beginning it has been used an antibody, which is quite a big molecule, of course, so it was not optimal. The main difference has been done by the introduction of smaller ligand, that's to say fragments and then oligopeptides, which is much better coupled with gallium as an isotope. That's an animal model, and these are the first human studies presented by the group in Heidelberg that indeed are pioneering this research with a gallium-labeled PSMA ligand. As you can see, there is a nice depiction of the tumor. But what's even more interesting, and that's the first full paper that appeared just last year, and I got a few images provided by the colleagues in Heidelberg. As you can see, the clear direct comparison of F-choline with gallium PSMA is clearly in favor of gallium PSMA, which is indeed able probably to cover the large number of studies that could still be false negative with the use of choline. That's another impressive example of F-choline as compared to gallium PSMA. And again, the target to background is impressively high. And indeed, at the last European Congress, we had a full session dedicated to that. It's probably the most rapidly growing new tracer in the area of cancer imaging. That's the original data from Heidelberg, in which in the large majority of cases, there was, in about 70 lesions, better visualization with gallium as compared to F-choline. So given that we are talking about German developments, I guess that the German colleagues are filling with good beer the glass, and most likely they will bring to great results in the future. There is an ongoing trial sponsored by the German cancer group about this topic, and very early we will get more information. And many centers have already developed this tracer. The more relevant alternative, and of course there is also a fluorinated one, which is under development in the US. It's patented by the Johns Hopkins, so it's something that may also have, let's say, a commercial interest, and the preliminary results have been presented here. And it's as promising as gallium, even if probably the quality of the image is a little bit lower, mostly related to the dimension of the ligand that is used. But nonetheless, this is definitely another interesting alternative for imaging, based again on PSA imaging. The alternative is most likely synthetic amino acid, which is a completely different pathway of evaluation. It's been developed at Emory, so it's again USA, with a synthetic amino acid, which is called fluorobutane, or FACBC, if you prefer. And the results have been published, and then we are also participating in international trial in this area. It's been demonstrated to be superior to the conventional imager that's available in the US, which is Capromab, but we also performed a direct comparison with choline. And again, FACBC demonstrated to be superior. That's one example of local recurrency. There are several examples, again, of FACBC as compared to choline, with better evaluation, better visualization with FACBC. So I guess that also in this case, we make an evaluation on a lesion basis, and it was always in favor of FACBC. So I guess that we are trying, given that the study is carried out in Australia, in the US, and in Italy, to fill the glass with good red wine, which may be an interesting alternative to the German beer. But it's mostly getting to the conclusion and try to be as objective as possible. It's definitely an exploding area, because 2 years ago we got about 200 publications on choline PET, and I did it a few weeks ago, and it doubled, and it comes to volume which are definitely very relevant. So choline PET is becoming, especially in Western Europe, widely available and routinely used, and it's even reimbursed in many countries. And it's with the introduction of F-choline commercially available, so quite easy to get access to. Nonetheless, there are pros and cons about the use of choline. Again, it could be available, but the diagnostic accuracy is sometimes suboptimal, especially when you deal with low PSA values and your sensitivity is in the range of 50%. You have to consider that you're much better than the conventional imaging, that especially for nodes and for bone evaluation at that early recurrency are extremely low, but nonetheless is not as high as it would be. So the bright future is just around the corner, hopefully, because a couple of new tracers are coming very, very soon. And I guess that we could be very happy in the next future. And let me, before thanking you for the attention, I would like to really deeply thank Gustav von Schultes, because he has been for years a pioneer, a master for all of us in the area of PET. And to me, give a lecture invited by him is just a great honor. So thanks indeed for your attention, and thanks for Gustav for inviting me. Thank you very much.